Dear ESTS members and webinar attendees, my name is Lieve de Piepere and I will be your host for today. This is a special extra edition of the ESTS webinars, specifically on how we, thoracic surgeons, are dealing with the COVID-19 pandemic. Thanks to our friends from J&J China, some of our Chinese colleagues were very happy to share their experience with different issues when dealing with COVID-19. Also, within the ESTS Learning Affairs Committee, we designed a survey on COVID-19 pandemic affecting our practice and especially our oncological practice. The idea was to share the results as soon as possible in order to help each other in some decision making. In a very short time period, many of you filled out the questionnaire, and I'm very happy today to be able to say that after the survey was ended only this weekend, we can already show you some of the early results. Maybe I can start with some housekeeping rules. So I would like to ask everyone in the audience, if you have any questions, you can use the right sidebar on your screen. You can see it there, where you see questions. And then you type in the speaker you want to ask a question to, followed by your question. This allows the speaker to prepare a little bit their answers for you. And after all the talks, we can have some questions and answers. So after all this, we'll have some time for questions. We'll make sure that all in order to information on how it's now to introduce you to Niccolo Daddi, our ESTS survey coordinator, who will discuss the early results of the.
Yes, I can hear you. I think we
Niccolo,
have some connection problem at the introduction, but I can hear you very well.
Okay.
Can you hear all
the
colleagues probably there? Hopefully they will hear me clearly. First of all, I would like to thank everyone for being here, our esteemed colleagues from China, as well as all the colleagues all around worldwide that are listening to us in this very particular time of our life and our work. So what I'm presenting here in 20 minutes is a 27 question and answer snapshot of a situation that we all know, basically, and there is steadily increasing in some countries, and in some other is we can see a little bit of less increasing numbers. But so far, we have more than 2 million of people affected by this disease, with 100,065 and 310 deaths so far. The questionnaire was basically done and open for a week. We have quite a fair number, good number of colleagues participating, over 400, and of them we have complete responses of 373. And where, as you can see in this pie, we have mostly a good distribution, mostly from countries that are already affected in numbers of patients, but also other countries. And this is a very, very interesting data that we received from all of you. The first questions of this 27 is in which type, second question, sorry, is in which type of institution? And as you can see, mostly they are coming from academic hospital. with a 71.60% of responses. And how many COVID positive patient is in your hospital treating? And the distribution is on the two sides. One is between 0 to 20, and the other percentage, high percentage, is over 200. And in the middle, you can see we have numbers, a fairly good number of patients recovered on this disease and actually treated for that. How is the COVID? Question number 4. A COVID-19 pandemic affected the normal functioning of your hospital, and that in this case was a general question. And as you can see, there is a considerably, so a significant emergency department activity. Only medical or oncological urgent surgeries are executed. Minority of ICU beds available for non-COVID-19 patients. So 53.33% of them. Are the healthcare personnel tested in your hospital? This was one question they were adamant to ask, basically, because we see differences in between the countries in Europe. And mostly there were yes, the answer, but only see if symptomatic and home isolated. How are the multidisciplinary tumor meetings organized today in this particular moment? And the question 6, we're getting more in-depth in this and the thoracic surgery situation worldwide. And actually, the answer in this case was a digital meeting using an e-platform, as we are using now in this conference between us. And this was used also in distance, not a big distance, with an e-platform, but with the same frequency. Question number 7 was also regarding the multidisciplinary decision influenced by COVID-19 pandemic situation. And most of them, the answer was no treatment decision itself, but a degree of treatment urgency is mentioned. And that was the basic answer from 54.50%. I don't know if you can hear me, because I see, yes, okay, good. So the question number 8 was, given the current COVID-19 crisis, we were asking from most of, to all the participants to select which of the following hypothetical patients you would definitely prioritize for surgery. And we were asking to put an order from highest priority to lowest priority. And basically the answer were fairly similar. The only one that was, in a percentage less, it was a case of 80-year-old patient with lower growing, partly solid T1A and 0 peripheral lung cancer. But mostly patients in between 55 and 65-year-old cases. In this case, the first one in absolute rate was a 55-year-old patient with normal pulmonary function tests and one disease, and cancer in the right lower lobe. It was the case to prioritize in this 5 cohort of patients. And the other one was a 65-year-old patient with normal pulmonary function and no comorbidities with 3 centimeter right upper lobe cancer. We will see also right in this questionnaire, but also from our colleagues, why all we are mainly prioritized in this sense. And the other 2 patients, 65 and 60-year-old patients, were put in the second line. What thoracic surgically patients are being screened for COVID-19 in your department? It was a question number 9. And the distribution, again, is well distributed. Basically, we have 3 groups. All symptomatic patients, and in this case, in and out patients, all inpatient contacts only, and all patients, inpatient and outpatients. So the distribution were in these 3 cases, and less in the second position, symptomatic patient with certain inpatient contacts, depending on underlying pathology, and only symptomatic patient in the emergency department. Question number 10 was on how are thoracic surgically patients screened for COVID-19 in your department. And most of the tests used is a nasopharyngeal swab, 90%. Chest CT is utilized, but I assume based on the nasopharyngeal swab. And the other tests, such as the blood test for antibodies, sputum, bronchoalveolar lavage, and other is in a different position. Question number 11 was, does the result of a test influence the surgical treatment of your patients? And mostly the answer was yes. A COVID-19 positive elective patient with symptoms will not operated on anymore. And other therapies, the answer was the basically positive elective patient with or without symptoms will not be operated on 14 days and will be rescheduled afterwards. So waiting 14 days, 2 weeks, and then reschedule the surgery. The question number 12 was, how is the preoperative oncological workup influenced by the COVID-19 pandemic situation? And most of the answer were on not at all, and all investigations are available in a normal time frame. And the other answer, most common, was only endobronchial investigations such as bronchoscopy, EBIS, are delayed or unavailable, and is basically we can assume from the airway contact of this kind of investigation. Question number 13 is, which of the following preoperative functional tests due to the COVID-19 pandemic situation? And the answer, most of them, at 63.45%, was all investigations are available as normal. Other possible answer were the spirometry with or without arterial blood gas analysis, and in the sequence also cardiopulmonary exercise test and the LCO correlated to spirometry test. Question number 14, it was, how is your preoperative contact with the patients influenced by COVID-19 pandemic situation? And most of the answers are from colleagues from worldwide, were business as usual, but with obviously hygienic measures such as social distancing, surgical masks for surgeon and or patient. And second position, but far, at 41.21% was I try to avoid direct contact with patients and I have as much as tele or video contacts as possible. All preoperative patients in the last, in a small percentage, contact are through tele or video calls. So most of them is business as usual or avoid contact with a teleconference. 15 questions was the 15th. Do you talk about COVID-19 with your patients preoperatively? And in this case, we had most of the answer was yes, but with a yes, basically, I don't want to, but patients ask about potential higher risk, and I tell them morbidity and mortality is higher in this case, in this period. And second position of yes was I don't want to, but patients ask about potential higher risk, and I tell them we don't know that yet, how it would be. Question number 16 is, how is the surgical planning affected by COVID-19 pandemic situation? And in our point of view, worldwide, we are a little bit facing considerably. So only medically or oncologically urgent surgeries are executed with a minimal staff and ICU beds available in worldwide, with a 47.50% of answer. How do you feel about the effect planning? And the response was, I agree with the current situation. This is what needs to be done. And most with a 55.77%, 67% to 221 responses. The question number 18 was, are you and your thoracic surgery colleagues involved in a daily care of COVID-19 positive patients? And the distribution, as you can see here, is between the two opposite. So no, none of us is taking care of them. And so it's 149. And on the other side, yes, special COVID shifts for other departments, like in example, ICU, IMC, emergency department. But also we have a yes, some of us is only but in surgical patients involved in the daily care of COVID-19. Question number 19 was what kind of personnel protective equipment measures are taken during a COVID-19 and negative thoracic surgical procedure? And most of us response is standard or equipment only for all staff. And in the second position, the FFP2 mask, glasses, gown, and face shield for anesthetists only, and FFP2 mask glasses for the surgical team. In the case of positive COVID-19 thoracic surgical procedure, most of the answers were on, as you can see, on the FFP2 mask, glasses, gown, and face shield for all staff in the room. And how is intensive care post-anesthesia care availability for thoracic surgery patient affected by the COVID-19 pandemic situation? In this case, we have a fairly distribution in between two answers. The first one was not at all, business as usual. And the other one was patients who standardly go to these units for one night are sent earlier to the ward, but some places are available. The questions number 22 was based on the use of the chest drain management for your thoracic surgery patient during this COVID-19 pandemic. And we are asking if it's different from your standard management. And it was a striking response, 81.11%, no, same system and same protocol used. And the other different answers we were asking were fairly distributed in a percentage that range in between 2.27% to 5.04%, but mostly the first, no, same system and same protocol used. Question number 23 was, do discharge criteria for your thoracic surgery patients during this COVID-19 pandemic differ from your standard criteria? In this case, we had an answer mostly over 50%, no, same traditional or enhanced recovery protocol. And other second position was yes, most patients are discharged earlier than usual, mostly because of bed capacity and fear of COVID-19 infection. Question 24 was on how is your postoperative contact with the patient influenced by the COVID-19 pandemic situation. And in this case, we have mostly two responses. One was, again, business as usual, but with hygienic measures, social distancing, surgical mask for surgeon and or patient, 46.23%. And the second response is mostly on 41.96% was, I try to avoid direct contact with patients, and I have as much tele or video contact as possible. Questions 25 was questions regarding any one of your department was tested positive for COVID-19. And the questions we were asking before is reflected in here, mostly no. And we have a 56.64%, 226. But also we have a fairly good number of physicians, surgeons, colleagues there were positive, 32.33%, and also other personnel such as nurses and health personnel as well. The questions number 26 was, how do you feel as a thoracic surgeon during this pandemic? And we were asking this because we just have a glimpse, an idea, and to all this information. And basically, as you can see again, we have a distribution between the two sides. The first was nothing different. I do what I can for my patients. And on the other side, most of the answers were 0.35% mixed feelings. I cannot give the best care for my own patients, but I can help a lot of patients in urgent need. And the last one is future thoughts. We had more than, this is not updated, but we have more than 100 answers. and basically with a lot of future thoughts of hope and hope that things will change and will hopefully, be safe for everyone. And this is my last question, 27. Thank you very much for listening. Thank you.
Thank you, Niccolo.
No problem.
This is a very nice overview, of course. I saw in the first slide that you had some answers from different countries all over the world. I don't know if you already had time to see any difference between countries in their answers, or is this too early?
Is it too early to call? As I put it down, is a snapshot, is a moment right now, and I think this help to understand what is the trend right now, what are we going to do, and obviously I am very interested to listen what our colleagues, esteemed colleagues from China, will tell us about the situation, because the first period is on their own hands, and they know better than us what they are facing at the moment and what they faced in the past. What is the basically what there is a lot of questions. I think they are coming on the right side. I see.
Yeah.
But I think again, this is a snapshot. It's a snapshot, and I think there are some differences from countries, for sure. But it's too early to call and to have a clear glimpse, a clear idea in what we are going to face and what we are going to try to do. But the thing is, basically, protection is for sure. I think the involvement is pretty interesting, different between countries. There are some countries where the involvement of the thoracic surgeon is more, and other where is less. I'm not telling about the academic institution, and not going to put out the questions of the academic between academic and non-academic. I think for us, in my instance, we are involved, but obviously in the urgent cases, and they are trying to keep us in a position where we can continue to do the oncological procedure as well, and try to keep the wheel of cancer going on, because there we have a lot of cases, a lot of patients coming in a list, and that is going to be a big issue, a big problem once the COVID situation will be.
Okay. Are you going to plan a second survey as well, a little bit later on?
Okay. Yes.
Yes. Are you going to plan a second survey as well a little bit later on to
yes,
compare?
I think it's sorry because the audio wasn't clear.
Yeah, no problem.
Of course, we are planning. We're planning for sure. This is again is a snapshot, is a moment, is a time frame in our period of life. I think it's most important to have an idea right now, to have a temperature of the situation.
Okay.
And obviously we're going to compare what we are having now with in the future time frame. I think probably May, June. Again, we're going to. It might be monthly based. We will obviously, of course, keep you updated and with the data, and to understand and better, and to be safe and to work as the best for the patients as well.
Perfect.
Thank you.
Thank you very much, and thank you for all the colleagues who filled out this questionnaire, of course. I see a lot of you already had posed some questions. Can I ask again that just to give the speakers a little bit time to prepare their answers for the questions. And if you have a question, please type in your question and type in to which of the speakers you want to ask this question, and then we can try to answer them a little bit more in detail. So I'm gonna pick out some questions anyway, but try to listen to the speakers first, and then try to pose your question to one of the speakers that they can answer after all the the lectures. Okay, our next speaker will be Professor Zhang.
Hello.
Professor, can you hear me?
Yeah, I can hear you. And you?
Professor Lanjun Zhang is the Director of Thoracic Surgery Department at the Sun Yat-sen University Cancer Center in Guangzhou. Professor Lanjun Zhang will talk about the graded diagnosis and treatment during the COVID-19 pandemic. Professor Zhang, we're listening to you.
Okay, thank you. Can you see the PPT?
We cannot see your slides yet. So you should enable your screen sharing on that button, in that actions button.
Okay.
Take your time. So you go to actions, then enable screen sharing.
Yeah.
Then you click on that, and then your blue button share screen.
It's okay?
Not yet.
Not yet. Share the media. It's okay? It's okay?
No, not yet. So if you
not
go to
yet.
actions,
so I go to the action.
Go to actions, then enable screen sharing.
Yeah.
And then you click on entire screen. So the small icon, entire screen. And then you have the blue button share. Then we will see your screen. Do you see that?
Yeah. It's okay?
No, not yet.
Not yet. Oh my God.
Is there anyone in the room who can help you?
来，你们谁来看看 ？Share media.
Yeah.
Yeah.
No, not share media, but enable screen sharing.
Yeah.
The first one. Yeah, now it's coming. Okay, and then you can go to your PPT.
Okay.
Okay, perfect. And then you can open it in the presenter's version.
Okay.
Great.
So thank you. Good afternoon, everyone. I'm Dr. Zhang, come from the Sun Yat-sen University of Cancer Center. So my topic is precaution against the COVID-19 for the lung cancer surgery during pandemic. This picture will show today the pandemic situation. We can see in China, we confirm cases is 84,000 cases and the deaths of the 4,000. But for the overseas, we almost 2.5 million cases was diagnosed, and the deaths was 172,000 cases. The new cases in overseas of China is
I don't hear anymore. Professor Zhang, can you hear us? Can any one of the other speakers hear us? Niccolo, can you hear Professor Zhang?
No, I can't. I think we should maybe move to the second colleague, and then we can, like try again.
Then we can come back. Yeah, indeed.
Yes, I think it's the best to everyone.
This seems to be, yeah, now he's out indeed. Okay, so this is live. Our excuses, but this is what it is during the COVID-19 pandemic. So maybe we go indeed to the next speaker, Professor Junfeng Liu. He is the director of the Department of Thoracic Surgery at the Ford Hospital of the Hebei Medical University. And Professor Liu will give us some more insights in the ward management during COVID-19 pandemic.
Okay, can you see the slides?
Yes, we can. I should just...
Okay.
Yep.
Okay, good evening, ladies and gentlemen. Thank you, Mr. Chairman, for giving me the opportunity to make the presentation. As we know, COVID-19 broke out in Wuhan in December 2019, and it soon spread all over China, even the whole world. But after 3 months combat, now it is basically under control in China. First of all, I'd like to say
we lost your
slides. Sorry?
We don't see your slides anymore.
Okay. Can you see?
No. We saw them, but now we lost your slides. So can you go back to actions and enable screen sharing?
Okay. Okay, 看不见了，看不见这个。Okay. Action. Huh? 选这个就选这个。就选这个。对，分享。Okay. 分享不了了。刚刚没选上。Okay. Okay. Yeah. Can you see the slides?
Yes, you're back.
Okay. Let me start from the beginning. Okay. Yes. Yes, as you know, COVID-19 broke out in Wuhan, Hubei province in December 2019, and it soon spread all over China, even the whole world. But after 3 months combat, now it's basically under control in China. First of all, I'd like to say my province, that's Hebei province, is not a high-risk area of COVID-19. This slide shows the distribution of COVID-19 in different cities in Hebei province from 30th of January to 17th of April. This slide shows the trend of new cases of COVID-19 in Hebei province in this period. In recent days, the new case of COVID-19 was 0. Okay. This slide shows the trend of cumulative killed and dead cases in Hebei province. In total, there are 338 patients diagnosed with COVID-19, 316 cured, and only 6 died. In our city, only 29 patients were diagnosed with COVID-19 and no patient died. Although our city is not a high-risk area of COVID-19, the control of the disease was not neglected. We rarely encountered huge challenges in treatment and management of patients undergoing selective and emergency thoracic surgery in the epidemic situation of COVID-19. About the management of world environment, all entrances of the hospital were closed except one left open. At the entrance of a hospital, the body temperature must be taken and recorded for the people who wanted to enter the hospital. At the entrance of a ward, the body temperature should be taken and recorded again. An epidemiological questionnaire should be filled out by all patients. The number of beds in the ward shorted down from 80 to 40. In one ward, one emergency room must be reserved for patients with fever. door handles and the table surfaces were sterilized twice a day. The floor was sterilized with chlorine-containing disinfectant twice a day. The ward was ventilated for 1 hour twice a day. So this is a main entrance of the hospital. The way in and the way out were separated. Body temperature must be taken for all people. This is the entrance of a ward. The body temperature was taken, recorded again, and then epidemiological questionnaire was filled out. The content of the questionnaire included the telephone number. In the past 14 days, have you contacted COVID-19 patients or asymptomatic infected? Have you been to Hubei province or the epidemic area? Did you have the symptoms of fever, cough, and sneeze? Did you return from COVID spreading countries? About the management of medical staff, the medical staff were trained on knowledge of coronavirus, pneumonia, self-protection for infectious disease, reporting policy of infectious disease. All staff must wear masks in the hospital. And any staff who have been to epidemic area in the past 14 days should be isolated in home for 2 weeks before returning to work. For the management of suspected patients of COVID-19, they must be isolated in a single room, usually a reserved emergency room. All patients must wear masks in the ward. Second or tertiary protection should be implemented in the medical staff contacting the suspected patient. Epidemiological investigation should be conducted for the patient. In addition, chest CT scan, blood routine, pharyngeal swab, nucleic acid detection of COVID-19 must be done for the patient. Daily life and medical supplies are strictly for exclusive use. Decision of whether to lift the quarantine must be made through discussion with the specialists of respiratory and infectious disease. The preparation of patients before surgery. Patients and their relatives must wear masks in hospital. Before hospitalization, patients and accompanying relatives should be examined for blood routine and CT scan to rule out coronavirus infection. The patient should be observed for at least 72 hours before surgery, and surgery can be performed after no fever symptom. Pre- and post-operative patients were not arranged in one room. In order to protect the surgeons and operating room staff, a lot of measures were taken. Before entering OR, body temperature must be taken and recorded for both patients and the staff. Any person who has fever will not be allowed to enter operating room. About the emergency operation for patients with fever, surgery was performed in a dedicated operating room. Sanitary protection must be implemented for surgeons and OR staff attending the operation. The number of people attending the surgery should be minimized as much as possible. All people attending the operation were not allowed to leave the operating room during the operation. The OR and the facilities should be thoroughly sterilized after surgery. For the management of patients after surgery, blood routine, chest X-ray were examined at 2 days after surgery. For the patients with fever, blood routine, CRP, and PCT were examined. If there was a low blood picture with lymphopenia, nucleic acid detection, epidemiological investigation, chest CT scan should be done. If patients with cough, short breath, we needed to pay more attention to coronavirus infection in order to rule out the disease. Chest CT scan and nucleic acid detection should be done if necessary. And last, I would like to show you the flow chart of management of surgery for patients complicated with infectious disease in my hospital. Before hospitalization, we must understand the history of infectious disease and evaluate the indication for hospitalization. After hospitalization, routine laboratory tests must be completed as soon as possible. If there is no history of infectious disease, routine laboratory tests are normal. Management should be done as usual, and the surgery should be completed as soon as possible. If the history of infectious disease was demonstrated with laboratory tests, for example, tuberculosis cannot be ruled out, discussion with the specialists of respiratory and infectious disease are necessary. The risk of operation and the dissemination of tuberculosis should be fully considered. If hepatitis A, B, C, or syphilis, or some other infectious diseases are diagnosed, discussion with the specialists of infectious disease or the specialists from corresponding department is necessary to assess the risk for operation. If the infectious disease is active, decision of whether or not to operate and when should be made after the discussion. So in summary, pandemic of COVID-19 poses huge challenge for thoracic surgeons. It increases the risk of surgery for the patient and risk of exposure to COVID-19 for surgeons and staff. Well management of the ward and the protection of medical team can minimize these risks. Thank you for your attention.
Okay, thank you, Professor Liu, for your talk. I will save questions for later on. So I will ask to the audience, if you have any questions for Professor Liu, please indicate that it is for Professor Liu. He can already look at your questions and think of some answers. Sometimes he will be able to type them, and otherwise he will come back after the lectures for the questions. So if you have any questions, you can pose them. Please state that it is for Professor Liu, then he knows to which questions he has to look. Okay, we see that Professor Zhang is back there. We had a connection problem, I think. So Professor Lanjun, Zhang, can you start all over again with your presentation? Then we can follow you from the start again.
Okay.
So in actions, you enable your screen. You enable screen sharing.
It's okay.
Not yet, no. So actions enable screen sharing. Then you click on the entire screen on that small icon, and then you have the blue button share.
Yes.
Okay, and then you can go to your PPT.
Okay. It's okay.
And you can go to the presenters version now.
Okay,
Perfect.
thank you.
Okay, we'll listen to you.
So sorry for my connection.
No problem.
So my topic is precaution against COVID-19 for the lung cancer surgeon during the pandemic. This picture just shown by Dr. Liu, so I will pass it. So in our cancer center is a top 3 cancer center in China. So we just focused on oncology patient. The Guangzhou, we can see here is 1,000 kilometers from the Wuhan. But Guangzhou, the pandemic freeze are the middle risk region, but the Wuhan is a high risk. During the pandemic freeze, our cancer center was construction a leading group to prevention and control the disease. So the president of our hospital will be chief executive, and vice president of our hospital and all the director of the individual departments will be the member of the whole group. We also invited a specialist on infection disease, intensive care unit, and thoracic imaging and thoracic oncology come in. The role of this group is to regularly online to sensitively evaluate the latest situation and assign a task, and developing a specific protocol and guideline on prevention, diagnosis, equipment supply, and something like this. So in our hospital, the priority and principle and the measures is top priority is to import prevention and domestic to containment, because we are located in the middle risk region. The principle is to treat the cancer in order. If the early staging, we can delay if it's possible, and ensure both physical and mental health of all the staffs, and fulfill social responsibility, because we still need to organize some team to go to Wuhan to give their help. And a measure we do the population flow control, and for all the patients we do the extensive screening. The protocol on contact, we do like this. In the outpatient clinical flow control, every specialist clinic with limitation 15 to 20 patients per unit. But in a common clinic with limitation of 40 patients per unit. For the infusion center flow control, we do the quota 180 patients per day, and we infuse the less than 2,000 milliliter per patient. And admission control, we change double room to the single room, and a single escort and a reservation only. In China, all the hospital down, we do the enter and the gathering control. So every visitors is no visiting. If the patient come, we should show the ID required and operation room restricted. Only essential staff can return to work. Some research and student was asked to stay home. And our dining room and canteen was closed. For the COVID-19 screen in the outpatient clinic and admission screen, we should do the epidemiology history and the symptom and the thoracic surgeon. All the patients we need this 3-1. And the nurse is strict ward management to under surveillance and daily body temperature measurement. And we still ask the patient to show the 14 days travel certification. It's a real-time update. And all the patients who need to admission and hospitalization, we need to do the thoracic CT scan. And expiration is 14 days. And all the patients who admit will do the nasopharyngeal swab for the viral RNA test by PCR method. And all the patients are admitted and before any invasion procedure. The expiration day is 7 days. The diagnosis of COVID-19 for the suspicious cases, any of the following epidemiologic history with the 14 days. So, for example, travel to the affected area, that means the high risk region, and very close contact with the confirmed cases, and living in the same community or confirmed cases. And at least 2 of the 3 following clinical instructions, such as fever, respiratory symptom, pneumonia, radiology, many infections, and the blood for the white blood cell counters normal or lower, or lymphocytes counter lowered. Excludes 2 consecutive viral RNA test negative with interval of at least 1 day. And confirmed cases, we do the suspicious cases with the positive viral RNA test. And discharge criteria is normal body temperature for at least 3 days, and a significant improves on the respiratory symptoms, and a significant improves on the imaging characteristics. And 2 consecutive viral RNA test negative with an interval at least 1 day. So this is show the differential diagnosis will comply with the influenza, common cold, and tumor fever. This is a protocol in our cancer center for the outpatient clinical care. We do like this. And we can also have the temperature fever clinic and isolation seat. The patient, if their temperatures are higher than 37.5 degrees centigrade, will send it to the fever clinic and make the screener and make the diagnosis. This is a protocol of pneumonia found by the thoracic CT. We have the protocol, and if the case was confirmed, and we will send to the 4 specialist hospital in Guangzhou. One is the infection hospital, is municipal hospital. Another is the second provincial hospital, and the 3rd affected hospital of the Sun Yat-sen University, and the Nanfang Hospital in Nanfang Medical University. So these 4 hospitals was conclusions. All the patients was diagnosed with coronavirus pneumonia. And we also have the guideline and protocol to follow up the patient. And in the CDC of China government, and in the Guangdong province CDC and our cancer center, we all have the guideline for how to diagnose the patient or screener the patient. This is documented. In the pandemic phases, we have the 4 phases. We can see these pictures in the end of the January to the middle of the February. The new cases in China is very high, ranging in the 3,000 to 4,000 cases a day. So at that time, all the city was locked down. So you can see the street was empty. We closed the public. So at that time, in our outpatient clinic is closed. We do all the endoscopy closed, and all the invasion examining are closed. We just do some selected operation. Majority of the operation was delayed, and no visiting, canteen closed, the meeting canceled, and the personal protective equipment we need. In the February 10 to February 23 is phase 2. At that time, we opened the outpatient clinic. In the admission, we just use the policy of the single ward. We selective operation allowed, such as the no more than 2 operation per room per day, through the dysfunction the 40 minutes, and negative thoracic CT and viral RNA test required. That means every every patient will receive the operation. So you need the negative the thoracic CT and the viral RNA test. But at that time, the endoscopy is closed. No visiting, no meeting, and personal protective equipment needed. But we do the many online service in our hospital. For example, we do the cloud clinic all the way from the history talking to prescriptions, admissions, and discharge online, and pay online, and we mail the medical report, biopsy slides, and drug. So you can see from the Fiber 10 to Fiber 13, we have online percentage is from the 17% to 28%. Flow control also, we at that time we do totally in our hospital we have the 1,040 and 485 beds, but in pandemic we just opened 836 beds, so we decreased almost 44% of our capacity. We cannot discharge with 24 hours of admission. We through the environment disinfection after discharge. We original bed reservation after patient to transfer to the ICU. So no new patient was occupying the beds. So no more than 2 operations per room per day, and no more than totally the 42 operations in total per day. In the February 24 to the March 16, we opened the specialist clinic, but with limitation only the 20 per unit, and double wards was allowed, but the operations no more than 3 operations per room per day, and this time can open the endoscopy examination. All the invasion procedure required thoracic CT negative and viral RNA test negative. But at this time, all the students need still stay at home, no visiting, the canteen closed, meeting canceled. In March 16 to now, it's a freeze fall. At that time, we can see in China, the local new cases is only less than 100 cases in the whole nation. But we have almost 1,600 of the import cases, because this time we will the top task is to prevention import cases from the overseas come to China. How about our department in during the pandemic? We do the personal protection equipment and gel. We tighten admission criteria. For example, is a survey of ESTS to show we priority pathological confirmed staging 1A to 3A lung cancer patient. If the patient with purified GGO and less than 1 centimeter, we suggest them to follow up after 3 to 6 months. We recommended the definite the patient, for example, is a central lung cancer required to do the pneumectomy and with a high risk of comorbidity and advanced age over 80. We suggest this kind of patient to do the chemo and the radiation. For the outpatient clinic, we do the protection and we do the patient flow control. In our department, we also do the gel. The script is how to the protocol to how to find and transfer the admitted patient with a fever. So we ask the attending physician to do the investigation of epidemiological history, symptom, and do the personal examination. And also we do the labor test and the radiation test. And we then send specialists to make a consult. And so you can see this nurse is to act as a patient with fever. So the nurse to do the temperature measure. And for the outpatient clinic, we do this kind of management. So in the hospital main entrance, we do the fiber screen at the entrance. And then we let the patient to do the admission screen. And also to show their the travel certification by government, we can show this. If the patient with 2 weeks not go to the high risk region, the pass will show the green one. So if the patient with the green one, we can admission. And all the patient with admission need to do the nasopharyngeal scraper for the viral RNA test. So this is the patient and with their top regional to do all the patient and the top region will to do the RNA test. And in the outpatient clinic, we still to do the investigation of the epidemiological history. And for the doctor in clinic, we do the level 3, the PPE. We wear the N95 mask, plastic facials, and glass with surgical gloves with the hand hygiene. And we will keep the safety distance for the 1.5 meters between the doctor and the patient. For the operation, we do a same, but we need to all the staffs, medical staffs, to do the fever screen when you enter the operation rooms. But we did it to do the more protection level than level 4. So this we do the open surgery and the robotic surgery. We do just as a same. The whole workload during the pandemic was decreased. These two figure to show after the vacation of Chinese New Year, we have the 2 weeks, 9 weeks. In the 4 weeks, that means in the 10 of from the 10 of February to 14 to the April 7 to April 10, the outpatient from the 2,000 up to increase to the 5,000 a day. And but the operation from the 31 cases a day to now we do the around is 100 cases. The totally we see comparing to the 2019, the same time, same period, we can see the operation was decreased to the 17.4%. So we decreased almost the 26%. But the CT examination was increased compared to the last year because all the patients needed to do the CT scan. For our department, compared to the last year, the same time, same period from the January and March, the operation we do 437 last year, but we decreased this year. We only do the 294. We decreased 32.7%. And for the lobectomy, we decreased the almost 39%. For the esophageal cancer, decreased 34%. For the rest of for the medullary tumor or the chest wall tumor, we decreased the 14%. So the conclusion is workload decreased from the 27 to 38% compared to the same period of last year. And extensive screening and viral RNA tests are key to preventing hospital infections. And strict pre-operative evaluation, including taking a special notice to the differential COVID-19 and other pulmonary inflammation and some multiple GGO, we should do the differential diagnosis. Some benign and low-risk GGO patient, we suggested to delay the surgery and have the follow-up 3 to 6 months. And we recommended definite chemo and radiation for the central type of the lung cancer required to do the pneumectomy, and a high-risk competitive patient and elder patient over 80s. And recognized and treat post-operative pulmonary infection. We should to pay attention to a patient who was infected of COVID-19. So if needed, we do this kind of patient to isolate it. And the priority staff protection, we do the PPE environmental disinfection. And finally, we suggest maybe in the future we need the negative pressure operation room and the transport vehicle is required, because maybe in the future the many the patient maybe has the viral positive, but it's with no symptom. So for this kind of patient we suffer from the lung cancer or esophageal cancer, I think we should to do the operation for them, but we need the more equipment. So that's my PPT. Thank you.
Thank you very much. Thank you very much, Professor Zhang. I think it was also very interesting to see for the people in countries who are not that far yet, that there seems to be a way to go before you can go actually to normal again. So I can imagine that there's going to be some questions about that. We just let people ask their questions, and we can go to our final speaker. Our final speaker is Professor Yuing Zhu. He's the Vice Chief of the Department of Thoracic Surgery of the Shanghai Pulmonary Hospital, Tongji University School of Medicine in Shanghai. Professor Zhu will give us some more insight in the challenges and the management of thoracic surgery approach during COVID-19. Professor Zhu, do you hear me? Okay, if you can.
Okay, here. Okay. Can you hear me?
There seems to be. There seems to be a problem with feedback of your audio. Okay, and then go to.
Pleasure to share my experience in our hospital. I'm Yuing Zhu from the Shanghai Pulmonary Hospital. My topic is the challenge and management of the thoracic surgery approach during the pandemic. As we know, WHO declared the coronavirus disease 19, COVID-19, as a public health emergency of international concern in the January 30, and March 12, WHO made the assessment of the outbreak of the COVID-19 as the pandemic. So let me see the characteristic of the COVID-19. It's a respiratory transmission and high contagious human-to-human transmission, and universal susceptibility. And not only the child and the old man, almost all ages is susceptibility. And the symptom is mild. Most patients have the mild symptom, just like a flu-like symptom, a cough, a fever, but maybe 20% have the severe symptoms like the ARDS, and till now, no specific medicine. Coronavirus has infected more than 2 million people in 200 countries. COVID-19 has been suspected controlled in China, but still in the stage of the outbreak in other countries, just like the European country. It's very difficult to prevent the COVID-19, especially in the healthcare facility, because of the high density of the people in medical institution and frequently turnover of the patients and their family. And they have the similar symptom between similar symptom between the patients with COVID-19 and other pulmonary disease. Patients with lung disease are more susceptible to COVID-19. Routine examination of the respiratory system, just like a bronchoscope, a lung function, it was a high risk to be infected. In our hospital, we the QR code for the information registering of the historical knowledge of the COVID-19 before entering the hospital, including the staff and patients and visits. With the information registration and temperature taking before they enter the hospital. Not only the visit, the patient and the visits, all the staff need to take the temperature and register the information before enter the building. In the outpatient clinic, we have the sufficient personal protective equipment, including the eye shade and mask and protective clothing. Patient in the waiting room, patient and company sit in the safe distance. Because prevention in wards, all the visits is not allowed in the ward. That's some challenge in the thoracic surgery because of the differentiate diagnosis between the patients with the lung cancer, especially the GGO-shaped the cancer, and COVID-19. Respiratory examination, such as the bronchoscopy and lung function tests, can easily cause the cross infection. But deficiency and during the pandemic, A patient with chest tube really need to company of the family members frequently turnover. Prevent of the post-operative infection of COVID-19. Medical staff are susceptible because of surgical exposure, surgical intubation, and ventilation. All the patient, most patient will be the local citizen, and some if the patient is not Shanghai citizen, need to stay in Shanghai for more than 2 weeks. Before they, all the information should be collected before admit to the hospital, such as the surgical type of confined operation, emergency surgery, and historical something like the symptoms, any history of the tourists to the Wuhan, and no contact to the COVID-19 patients. The recent examination in something like the computer blood count, chest CT, and COVID-19 test not necessary. All the family members may be the potentially to accompany with the patient will be investigated. That's the hospitalization. All the operation will be the confined surgery, and it's the time limits the operation. Invasive lung cancer, a pathological diagnosis as lung cancer. Solid, not then radiological malignant features. Pure solid nodule 2 to 3 centimeters, usually highly suspicious of the lung cancer. We should do the PET-CT. The SUV is high. Part solid nodule with CTR larger than 50%. Tumor size increasing during follow-up. That's the chest wall, some malignant chest wall tumor and mediastinal tumor is a candidate of the operation. That's emergency operation, trachea and carina surgery with risk of apnea. Some emergency operation, including the traumatic pneumothorax and the post-operative BPF. Emergency surgeon also including the empyema and tuberculosis empyema. The pure GGO is the operation of the pure GGO. Although the size is larger than 3 centimeters, is postponed. That's the paper the recently published classified the COVID-19 guideline. The paper classified the situation to the phase three phase. Phase 1 is few COVID-19 patients in we have the few COVID-19 patients, and so we do it in the phase now. Stay at the phase 1. That's the mean the few COVID-19 patients in hospital resource intact. As example, the ICU beds, ventilators, clinician, and personal protection. trajectory should not be in rapid relation phases. The candidate of the operation is same as our hospital. The phase 1 means to the many COVID-19 patients, resource limited, and the COVID trajectory within hospital in rapid escalating phases. So that means the surgery restricted to the patients like to have the survivorship compromised if surgery not performed within next few days. The phase 3 is a hospital resource predominant route to COVID resources critically limited. The surgery restricted to the patients like to have a survivorship compromised if surgery not performed within next few hours. That's the we set up the SOP for bronchoscopy and pulmonary function tests. The work well. What we call the level 3 prevention equipment. So we set up some standard for the management of the surgical process, but no more than 2 surgeons each group per day, and no more than 2 surgery each theater per day, and more than 1 hour's disinfection during the interval of the surgery. Only consultant surgeon will be the operator, no training course. Level equipment surgery. Third level protection for the emergency surgery. That's the management of the surgical. The commandant the use of the personal protective equipment for surgery when the management suspected or the confirmed COVID-19 patients. In hospital, just for some emergency operation, the operating room will be the negative PAPR preferred for long operation and fit and 95 mask and with eye protection goggles or full face shields. This possible and AM level 3 surgical gown or the coveralls. And the double high cuffs, surgical gloves, and the shoes worn should be full resistant and easy to be decontaminated. The hand hygiene prior and after dominant and or the dolphin PPF. That's the ICU. Every 2 patients with at least 1.5 meter distance in ICU. That's the safe distance. And 1 room for patients with fever in each ward. That's let me see the process. You can see from the February 5 to the February 17, the number of the infective cases is very high. It's a high risk to do the operation. So we stopped all the risky examinations, something like bronchoscopy and lung function test. So almost all the operation is postponed. except the emergency. And from the February 15 to that's March 6, the number of the infected cases is decreased almost, except the Wuhan. All other city is on a very low level of the COVID-19. So we gradually return to work. So from the February 17 to March 6, we performed that's the thoracic surgery in the COVID-19 pandemic. 78 male and 54 female, and 83 from Shanghai and 45 from the other province. Average age is 58.4, something like that. Most cases is the lung cancer, lung disease. Most is the lung cancer. Median sinus tumor is 5, and empyema and pneumothorax and trachea stenosis. 74 pure solid nodule and 28 partial solid nodule and 11 intraluminal lesion. There are 7 benign diseases. Pre-operative diagnosis is malignant. The result is the 4 cases of the granulomatous lesion, and 1 case of the medial central lymph node, and no malignant cells in 2 cases. That's lesion. That's very like the malignancy, and the PET-CT is positive. Well, the lobectomy is 88.5, and sleeve lobectomy is 12, wedge resection 7, and the segmentectomy 4. And we have 2 pneumonectomy. There are four cases of the complication, and 1 is the SVC injury, blood loss to 1,200. And 1 case is post-operative bleeding and the reoperation. 1 case of the cerebral infarction, and 1 case of the pulmonary artery embolism confirmed by CT/PA. The paper is the author of this paper is from the Wuhan. We know the Wuhan is the very serious, very high risk district. Their experience is the case fatality rate of the post-surgical patients diagnosed with the COVID-19 was 27.3%. The situation onset post-operative leukocytosis with the lymphopenia and the post-surgical CT changes overshadowed the early signs of the viral pneumonia. Dynamic symptom monitor serious chest CT and the test for viral RNA and serum antibody improved the chance for prompt detection of the COVID-19. The summary: the operation is follow the guidelines of the COVID-19 treatment in China. Adjust the indication of surgery to reduce the risk of the transmission. strategy of the prevention and the control adjusted according to the transmission scenarios. Confined and emergent operation is feasible during pandemic and after the prevention and the control. Thank you very much.
Thank you, Professor Yiming Zhu, for this very nice lecture. We have had all the lectures right now. I would ask people if they have any questions that we could bring up to the faculty here. Then we can do this. A lot of questions have already been answered by the faculty I see. Let's try to pick out some of the questions. Maybe first question to Professor Daddi. After the pandemic, hospitals return to normal or will left in some permanent change? Wait, I cannot see that question.
Yeah, this is a very good question. I think some hospital, I mean, in our experience, I'm talking about by our experience mainly, we will have one part of the hospital is that it will be dedicated on COVID patients still. We do believe that this COVID, unless there will be a vaccine, there's nothing, will be gone until we don't have a cure for it. I think maybe, correct me if I'm wrong, if my esteemed colleague from China can correct me, I will be very happy to do so. But I think we should keep our line very to protect everybody, to have at least what they are going to do here, to have one pavilion of the hospital dedicated to the COVID-19. The question is for me to our colleagues is, do you think the late results of this infection, like interstitial disease of the lungs and other problems, did you face already some of them, or on the patients that are now? Because we see that you are getting on phase 3 basically, and we're very interested to see all your measures to protect the population. But what do you think about the late problems? What are they? And you already see some of them, or no?
Okay. Together with this question, I also see there's a question about are all of you experiencing an increase in tracheal injuries after a long time of invasive mechanical ventilation? So indeed, in total, do you see any late complications of the disease after patients are not, let's say, not positive anymore? They don't replicate the virus anymore. But do you see this? Can anyone of the Chinese colleagues answer on this? We have some feedback here. Anyone who wants to answer this question? Do you see any of the late complications? Do you see any fibrosis of lungs, any problems, any tracheal stenosis? And what do we do about that? Professor Zhang? Want to answer? Yes? Okay, Professor Zhang?
Good questions, because we are never admission the patient with the COVID-19 in our cancer center. We don't have the experience about the long time of ventilation. Does this can make the trachea injury? But for the experience before we treat the oncology patient, if the patient with in ICU with a long time of the ventilation for the complication, in the pulmonary complication, we found some of patients to have the trachea injury because of the ventilation tube. But we can monitor it because in the ICU we can monitor it. If they have the case, we can evaluate the patient. We can do the whether we can do the latest repair or do the second time of the surgery. But for the COVID-19, because all the patient was sent to in Guangzhou, sent to the very special hospital, and also in Guangzhou, only some hundred of the cases was admission in the hospital. So we didn't see the many of the long time ventilation patient.
Okay, thank you. Anyone else who wants to comment on this? Professor Yumi, Professor Junfeng Liu?
Sorry?
Okay. Then maybe it seems to be difficult here. Maybe another question I can pick from here. There's a lot of discussion about the screening, PCR screening versus CT screening. I see in all of the centers you do both. How is it managed? Is it PCR first? Is it how does it work? Can I start with Professor Yuming Zhu?
Hi. Yeah. You know, in China, Wuhan is different from the other city. Maybe more patients, more infected cases in Wuhan, but in Shanghai, maybe less cases. So in our hospital, we from the entrance, we screen all the people enter the hospital, including the history of the tourism, and take the temperature and the distance. In fact, Shanghai Pulmonary Hospital is not a designated facility for the COVID-19. So no cases of the COVID-19 hospital. So I don't know the other hospital how to screen the infected cases.
Okay, I understand. With the screening of the patient, so first temperature, and the patients that are having a high temperature are getting the patients with a high temperature. I try to mute your feedback. It's very difficult. Maybe I can go to. So first you do the temperature, and then you go to PCR in all the patients with a higher temperature. And when do you screen with CT then? Do you have any? Professor Zhang, can you answer? Did you hear the question? Did you hear the question?
No.
Okay, so there's a lot of questions about screening. First, you screen with temperature, and all patients with a higher temperature are getting this swab, the nasopharyngeal swab. swab, and what patients are getting a CT? All of your patients for surgery, or not all of them?
Thank you. All the patients who were admitted in our cancer center needed to do the thoracic CT and the nasopharyngeal swab for the viral RNA test.
Both.
So it's a principle.
Okay. Okay. And let's say if the PCR test
if
is
the patient with a fever, high temperature fever, we send them to the fever clinic to make the console and to make the more intensive screener. For example, no matter for the nasopharyngeal swab, and also do the blood test for the antibody, IgM and IgG.
Okay. Okay, thank you. Professor Junfeng Liu, same in your hospital?
Yes, in my hospital, yeah, if the patient wanted to be hospitalized in the department of thoracic surgery, they must provide the recent CT scan results and blood routine results. Yeah, if the patient with fever, just like the Professor Zhang Lanjun's hospital, we send the patient to the fever clinic.
Okay. Maybe another question that comes back is, what do we do with people that have a chest drain and an air leak? Could that be an extra problem because of aerosol production and spread of the virus? What do you do? Do you take extra measures or not? Did you hear my question? Mr. Junfeng Liu?
Yes, if there are air leak in the chest drainage, yes, we must until the air leak stop and then remove the drainage.
Okay, but you don't take any other measures because of the...
Yes, if a very small leak, we just wait.
Okay. In the other centers as well, Professor Yuming Zhu?
在那个我的医生，我这里脸都没了，现在又出来了，对，没声音。
Oh, Professor Lanjun.
Niccolo.
Same early treatment as in normal patients for you? Professor Lanjun?
Yes.
Did you hear the question about the chest drains?
What kind of question?
So the question was, in patients with a prolonged air leak, do you do something else than you would do in another patient because of the COVID-19 pandemic? There's aerosol production. This could be more a problem in current times with people with prolonged air leak. Do you do something else or not? Do you retake them?
For the post-operation patient with prolonged air leak, you mean how do we management?
Yeah, indeed.
Is right? Routinely, the prolonged air leak is a common complication after lobectomy, especially for the segmentomy and for the vaginal resection. For the lobectomy, I think the mortality is lower than the segmentomy and the vaginal resection. So the first will make the evaluation, the degree, how the degree of is a grade 1, 2, or 3 of the prolonged leak, PAL. And if the grade 1, we just keep the thoracic drainage, and we don't need to do the operation to repair or to do the negative pressure to drainage. If the patient has degree 3 and last for 5 days, so we try to do the treatment, such as we injection some gel or some the glucose and something like that. If the failure, we can do the operation. But if the patient with grade 1 or grade 2 air leak, and with within the 5 days, we can just waiting and observation.
Okay. Then thank you. Then we had some questions about mortality. We have seen that that one paper about more than 20% mortality in COVID positive patients in thoracic surgery. Does any one of you have experience with operating on COVID positive patients and their post-operative course? So you don't, I think, Professor Lanjun Zhang? No?
No. Ever do the patient with COVID-19 positive?
Okay. Professor Junfeng Liu? Wait, we cannot hear you yet.
You encounter any, sorry, can you hear me? Okay.
Yeah.
Patients with COVID-19, so we also have know the experiences. Okay, thank you.
Okay. And in the Shanghai Pulmonary Hospital?
Yes, the same as with my colleague. Infected the COVID-19 infected have been detected in our hospital.
Okay. Okay. Good. If anyone in the audience has any particular questions, you can ask them, because I cannot find everything back in all these questions. We will try to have these questions answered as much as possible, maybe through another medium. But it's 2:45. If you have any questions, you can ask them. I see there's some coming in. There's another question. How do you currently consent patients for lung resections? And which risk do you explain to your patients? There was also one of the questions we asked in the in our survey. So maybe you can also comment on that. I come back to Professor Junfeng Liu. So how do you currently consent your patient for lung resections?
Okay, do you explain the risk to the patient? Okay.
Yes.
Okay, yes. I think the first risk is bleeding, and now the vast lobectomy or lung resection is safe. I think the most common complication in my hospital is post-operative bleeding. Yes, another is infection. The third one is respiratory failure. Okay.
Sorry to interrupt you, but this is for normal lobectomy. In COVID-19, do you explain it in another way? Do you say, okay, now we have more risk because of the pandemic, or not? Don't you mention it to your patient?
Yes, if the patient complicated with COVID-19, I think it will add risk. But just like what I said, I didn't encounter any patients with COVID-19. Sorry.
Okay. But you consent your patient about this or not?
Sorry?
Do you consent your patient on beforehand on the outpatient clinic that if they get if they get positive, then they can have a worse outcome or not?
You mean should yes tell the risk of to the patient?
Okay.
Yeah.
Any other comments? Professor Yuming Zhu, you want to add something on that?
I cannot hear.
We have a very unstable connection with. We have a very unstable connection with you, Professor Yuming Zhu. I think it's 10 to 3. I think it was a very interesting and a very helpful, to me at least, webinar about COVID-19 for thoracic surgery. We will post this on our media as soon as possible, so it will be available for everyone, as well as the results of the survey. So thank you to all speakers. Thank you to Professor Niccolo Daddi. Thank you to Professor Lanjun Zhang, to Professor Junfeng Liu, and Professor Yuming Zhu to give us more insights on these problems. I hope that all of you can stay safe and be available for your patients, of course, during this pandemic. Thanks again, and see you next time.
Oh, thank you. Thank you, Liven. Thank you, all the speakers. I'm very happy to share and from the speaker. Oh, no. Oh, thank you very much.
Thank you very much.
Thank you.